Good afternoon, everyone. Good morning to some on the West Coast. Thank you all participants for being here for this informative virtual forum on medical mistrust. Happy that you could take the time out of your day and make the time at this hour to join us for this forum. A few introductory remarks. Our presidential initiative from Dr. Warren Ng is Capture Belonging. And that initiative is a place for justice, equity, diversity, and inclusion. And it's meant for every member of ACAP to feel welcomed at home and be about the business of the mission of ACAP, which is to serve and help the well-being of the children and families that we seek to help. A little bit about mistrust we'll talk about just after some introductory remarks by Dr. Warren Ng.
Hello, I'm Warren Ng, ACAP President. Thank you for tuning in to our Capture Belonging virtual forum on medical mistrust, where we will hear from the experts about the historical origins of medical mistrust in BIPOC communities. We will also explore in detail how racism and medical mistrust continue to hamper our efforts around healthcare access and utilization, particularly in this era of the evolving COVID-19 pandemic. We hope that any strategies and recommendations discussed in this forum will ignite your curiosity and enlighten your understanding and engagement in addressing medical mistrust in BIPOC communities and in your own care settings. I am grateful to Dr. Melvin Oatis, who serves as chair of our Capture Belonging initiative, and Dr. Tashalee Brown, our ACAP's inaugural DEI Emerging Leaders Fellow to the ACAP Council, both for serving as co-hosts and moderators for today's discussion. I am also grateful to our esteemed speakers, Dr. Susan Reverby, Dr. Leon McDougle, and Dr. Eraka for sharing their expertise and their knowledge with us. Throughout our presidential initiative, we will continue to present resources and create opportunities for important discourse and dialogue on critical issues such as this. I also welcome your ideas on how we can further these dialogues. As we seek to gain a broader understanding of systemic racism's reach and influence on mental health inequities, I am reminded of this quote by Bell Hooks. How do we hold people accountable for wrongdoing and yet at the same time remain in touch with their humanity enough to believe in their capacity for transformed? It is my sincere hope that through our initiative, we will gain a greater understanding of our collective humanity and increase our courage to transform ourselves and our systems to implement the most effective, loving, and appropriate actions towards achieving mental health equity for all of our children, families, and youth that we serve. As Bell Hooks also teaches us, when we choose to love, we choose to move against fear, against alienation and separation. The choice to love is a choice to connect, to find ourselves in the other. Thank you for joining us today.
We're thankful for the remarks of our president, Dr. Warren Ng. And now we're going to begin our forum on medical mistrust. Just a few housekeeping things. We're going to have questions at the end. And so please, if you want to put questions in for the speakers, there's a Q&A box, put it there. The chat function will only allow you to speak to the panelist if there's any kind of technical difficulties, but hopefully there won't be any, and you'll be able to just put everything in the Q&A box for the speakers. So what is medical mistrust? It's anything that allows or doesn't allow people to engage in the medical establishment, either because of historical factors or ongoing factors that leave it such that people don't trust, they're not able to put any faith that the system can help them. So what we're going to hear from our esteemed speakers today are the factors that has created such a system in which we're in right now, and what are the things that we can do to sort of disentangle and help for trust to be restored. So our moderator Dr. Tashalee is going to introduce each of our speakers, and Tashalee Brown is our Emerging Leader DEI Fellow to Council. So welcome, Tashalee.
Thank you for the introduction. So good afternoon, everyone. So in today's Medical Mistrust Forum, we're going to hear from Dr. Susan Reverby, who will give us a historical perspective on medical mistrust. We'll also hear from Dr. Leon McDougle, who will discuss the pervasiveness of medical mistrust in the context of COVID-19. And also Dr. Eraka, who will provide strategies and supports to help address medical mistrust and promote cultural understanding. As stated before, question and answer panel will be at the end of the discussion after the last speaker, but please feel free to enter your questions into the Q&A box as we go through the talk. So now I'm pleased to introduce our first speaker. Dr. Susan Reverby is the Marion Butler McLean Professor Emerita in the History of Ideas, Professor Emerita of Women's and Gender Studies at Wellesley College. She's a historian of American healthcare, women, race, and public health with a focus on equity and ethics. Her major research has been on women's health, women as health workers and professionals, and the ethics of public health and research. Her first books include the co-edited America's Working Women in 1976, Healthcare in America, Essays in Social History in 1979, and her monograph, Ordered to Care, The Dilemma of American Nursing in 1987. Her next project has focused on what is often called the infamous Tuskegee syphilis study, the 4 decades long from 1932 to 72 US Public Health Service research study in which African-American men were deceived into believing they were being treated, not monitored, for their disease. She edited a book on this study called Tuskegee's Truths, Rethinking the Tuskegee Syphilis Study in 2000, and wrote a book on the study, Examining Tuskegee, the infamous syphilis study and its legacy. She was also part of the legacy committee that led to President Clinton offering a federal apology for the study in 1997. Dr. Susan Reverby's research on immoral government medical study in Guatemala between 1946 to 1948, where men and women were given syphilis, led to a US government response from the secretaries of the Department of State and Health and Human Services, and an apology from President Barack Obama to President Alvaro Colom of Guatemala. I'd like to thank Dr. Reverby for her presence today.
Thank you very much. I'm really honored to be here, and I hope this adds to our conversation. So slide 1 is just a joke. Slide 1 is just a brief explanation of who I am and what I've done. Maybe go back to the first slide, please, for a second. I just like, this is a joke in my family, which was that when the doctors opened up the patient, the doctor says to each surgeon says, wow, the patient really did have butterflies in their stomach. So I want to really probe the history of medical mistrust, and I will argue here that we need a different story than the traditional one. Normally, the narrative usually starts with the assumption that trust should or has existed between a patient and their doctor in the case of medicine, or the public and government officials in the case of public health. Mistrust then is seen as some kind of aberration, usually the fault of the patient or the public because of misinformation, failed communication, manipulated politics, or lack of demographic concordance. In turning this historical query around then, let's start instead by thinking about whether trust between doctors and patients and public health officials and the public has always been normative. Okay, 2 slides forward, so not my name, the next one. Thank you. Okay, as one psychiatrist wrote several decades ago, patients have always grumbled about doctors. Plato was angered that doctors treated patients like slaves. And Chaucer declared that his doctor believed that gold in his pocket was the best of all treatments. Jokes about doctor God complexes abound. The one my doctor family told, next slide please, was of the doctor waiting his turn outside the pearly gates. Suddenly a figure in a white coat and stethoscope whizzes past him and is let through. Annoyed, the doctor queried St. Peter, "Who was that?" "Oh, him," Dr. St. Peter replied. "That's God. He likes to play doctor." Deference, therefore, and dismay, trust and distrust have always been part of the medical encounter, as fear and need often clash. Next slide. In his famous 1984 book, The Silent World of Doctor and Patient, Holocaust survivor, bioethicist, and psychiatrist Jay Katz argued until very recently medical and legal relationships and entitlements kept patients out of the process of decision-making in which the harms of therapeutic alternatives could be concerned. As patients, we are allowed sometimes to refuse treatments, he said, but the idea that we might make decisions too about what should be done didn't really emerge till the 1950s, and even then we were somehow supposed only to trust. Next slide. Much of the revolt against this view was led by feminist health advocates and Black and brown political groups like the Black Panthers and the Young Lords, who understood that the assumed blind trust was embedded with paternalism, sexism, class bias, and racism that had led to morbidities and mortalities. In turn, however, next slide, patients who fought medical authority were often labeled non-compliant or sometimes the careless consumptive or the recalcitrant patient, especially when class, gender, and racial differences between doctor and patient prevailed, as historian physician Marion has argued. Next slide. Or in my very bad piece of art, after 6 months of trying to use a CPAP technology that never fitted or didn't work, and then was proved to be cancer causing. Slide 3. Next slide, thank you. Historians have been examining how, quote, race is part of what my colleague Evelyn Hammonds calls the logic of difference that is so embedded in the practice and thinking of medicine. We have continued to document this by exploring the systems of medical technologies like the spirometer to measure lung function, the assumption of differences in pain tolerance, next slide, or in multiple algorithms that climb out of centuries of thinking and are embedded in what is thought or taught. Next slide. The social structural experiences of racism is often hidden, however, and some vague concept of race comes into medical logic. Similarly, it wasn't the COVID pandemic that led to mistrust of public health officials and their advice. The tension has always been there since the first public health providers in Germany were known as the medical police. First slide. Thank you. In comparing two smallpox epidemics in 20th century US, for example, historian Judith Levitt found there was a major outbreak in Milwaukee in 1894. Political wrangling between the elite health officials and the immigrant population over vaccination and isolation led to a month of rioting and refusal as smallpox reigned. In contrast, next slide. In 1947, the need to counter an outbreak in New York City was accepted by the public, who stood in hours to get their vaccinations, that the epidemic never developed a foothold. The difference, the historian explained, was that the officials in Milwaukee tried to strong arm their immigrant citizens, while New York health officials tried more cooperative programs. Milwaukee went after immigrant communities more than those populated by the American-born, while New York's program was more citywide. Volunteer groups in New York made the vaccination campaign work, while the health department in Milwaukee did not energize citizen groups. Educational campaigns in New York were more culturally sensitive, while Milwaukee only used the power of the state and deployed it. Trust and little disease in one place, distrust and lots of illness and death in another. What the health departments did in the political context of the publics they served mattered. Trust and mistrust were being created. Medical experiences are also tempered by the concerns that since medical science grows through a medical experimentation, how sure can a patient or the public be they are not being, quote, subjected to science knowingly or unknowingly? Slide, please. Indeed, some of our earliest movies, from The Cabinet of Dr. Caligari, slide, The Island of Lost Souls, slide, or Frankenstein, all reflect the fear of the deranged but dedicated scientists experimenting on the natives. Next slide. The problem is even worse, since many committed doctor scientists also experimented on themselves, believing that suffering for science was meaningful. If the reasoning sometimes went, if I am a scientist doctor and I'm willing to do this on myself or my family members, why shouldn't this medical golden rule, do unto others as you would do unto yourself, lead to trust? Next slide. But as I argued in the days when I was still a brunette, nearly 2 decades ago with famed New York Times medical writer Lawrence Altman, who wrote a book on self-experimentation, I said, there is at least a danger here of what might be called the pyrite rule, that is fool's gold rule. Doing unto others what you might do unto yourself is hubris and dangerous because it posits a false kind of equality that doesn't usually exist. A researcher's motivations for undergoing experimentation may and often will differ substantially from those of a lay subject. The participant may have a different set of concerns, understanding of risk, or willingness to undertake risk. Slide. In sum, the existence and sometimes even the demand for trust has always been a contested category. Consider that so much wouldn't be made of it if it was normative or always obtained. But people have always fought medical public health authorities, whether with their feet, by not showing up, refusing to participate in clinical trials or take vaccines, scoffing at the prescribed treatments and self-medicating instead, making fun of doctor authority, rioting in the streets, or demanding a different kind of relationship. We also have to consider, I think, that publics and communities know about this past as they become bystanders to what has happened in medicine. When an awful and tragic medical or public health event happens and is covered by rumors, whispers, and media, it becomes part of the knowledge of a community, whether or not the facts are correct or not. As anthropologists and political scientists have identified such memories, they can become condensed symbols that evoke rich and vivid images, arouse emotions, and supply instant categorization and evaluations. Thus, rather than assuming that patients or publics are somehow backward or paranoid, there are butterflies in their stomachs after all, it is critical to think about how such condensed symbols are the meaningful ways people organize their understanding of the world. For as novelist Elif Shafak writes, legends are there to tell us what history has forgotten. Historians have written extensively about the experiences of African Americans with the healthcare system in particular and public health systems, and the lasting impact of such memories or legends so that they can be known and not forgotten. Under slavery, for example, physicians, often slave owners themselves, slide please, testified to what was called, quote, soundness, an enslaved person's overall state of health and by extension, his or her worth in the marketplace. Soundness was not just a measure of health, but also of character. And thus, as historian Charlotte Fett in her marvelous book, Working Cures, puts it, quote, the capacity to labor, reproduce, obey, and submit. Learning not to trust the doctoring of white physicians, the survival of enslaved people depended, slice please, upon a wide variety of Black healing practices, conjuring, hoodoo, use of root doctors, and a strong belief in listening to the individual's concerns and placing them in the context of the community. Given the limits of the regular doctor's medical armamentarium, the herbs and roots and communal understanding of enslaved healers, usually women, were also often used by the white doctors. Acknowledging such women's authority was, of course, not part of that process. Even into the 1930s and 40s, Black families would rely upon the knowledge of enslaved ancestors as part of an ethic of self-reliance. Why trust the racism and expense of medical physicians when family lore was more trustworthy and a relational understanding of health more practical? Historians, too, have pointed out the experimentation that took place under slavery and in the post-emancipation era and its existence in memory and legend. Fear of the so-called night riders and night doctors who raided graveyards to find cadavers for medical student learning, and even the concerns that such bodies might be stolen before the individuals even died, was not just a myth, as the finding of what's called bones in the basement of many a medical school can attest. Much recent scholarship, too, has focused on the work of Alabama-born J. Marion Sims, slide please, considered the father of American gynecology for his work on developing a vaginal speculum and a surgical cure for vaginal fistulas. Made famous by the Robert Thome painting from 1952 as part of a series called Great Moments in Medicine, it was reproduced by the pharmaceutical drug company Parke-Davis and could be seen in doctors' offices around the country and in Canada. Lucy, Eraka, and Betsy, the enslaved women that Sims bought and then practiced upon, remained seemingly frightened and nameless in this photograph and in memory, and nameless until the last few decades. Concerted efforts by historians and community members has led to a movement to bring them back as the slide, please, mothers of gynecology. After much organizing, Sim's famous statue in New York City was moved in 2018 from its place along Central Park on Fifth Avenue across from the New York Academy of Medicine to his grave in Brooklyn. And monuments of various kinds to these women have now appeared, as with this, next slide, please, 15-foot statue in Montgomery, Alabama, and in commissioned art. Next slide, please. Thus, the remembering of both slavery and experimentation has added new condensed symbols about the dangers of trusting American physicians and a way to deal with this history. Perhaps the most often cited issue of the history of mistrust comes from the use and abuse, as two bioethicists put it, of the US Public Health Service study of untreated syphilis in Tuskegee and Macon County, Alabama, mostly known as the Tuskegee study. Next slide. These are some of the men from the study. Lasting for 40 years between 1932 and 72, it left more than 400 African-American men untreated for their third stage syphilis and ignorant of their disease state, as well as the more than 200 controls who were not ill, as they were all watched and told that the aspirins, vitamin tonics, and iron rubs, even diagnostic spinal taps, were a cure for their so-called bad blood. While articles on the study were published throughout the decades, its coverage in 1972 through the work of a whistleblower and journalist led to a national outrage, a federal report, lawsuits, Senate hearings, and the memory of misuse and no trustworthiness seared into national knowledge. From the very beginning, the stories began that the men had been given syphilis by the government doctors, not lied to and watched over the decades. Next slide, please. So this picture is reproduced all the time. I actually even saw it last night on a PBS program about Dr. Fauci. When the photograph is used, sometimes it's cropped, so all that you see is the syringe and with a white hand and a black arm. And if you don't know that it's a blood draw, which you can see in this picture, it looks like he's being infected. So the assumption is made that this is an injection. It's reiterated over and over. Every time a new public health issue comes up since then, whether it's AIDS, abortion, or COVID-19, or even the debate over the Obama health initiative, the specter of another so-called Tuskegee has been raised. It is doubtful now, however, that the study in Tuskegee, Macon County has been over for more than half a century, that its details are even remembered. Sometimes the name Tuskegee is unfairly invoked as a synonym or condensed symbol to sum up lifetime of racist experiences. The best examples of this are two Saturday Night Live routines. Next slide. One in 2006, where the patient basically doesn't want to be treated and starts yelling. We know what this is. It's Tuskegee. And then the next slide, please. This one in 2001, where the doctor on the slide is supposed to be getting his family to get the vaccine, and they keep saying, no, no, it's all about Tuskegee. Most journalists often raise a sentence or two about the study to explain African-American resistance to medical demands without really understanding the daily experiences that make this concern not merely some historical holdover. What they don't say when they talk about the study in Tuskegee is, for example, if in fact the families had been given 40 acres and a mule during Reconstruction, or there had been national health insurance, the men in Tuskegee would not have been as vulnerable to the offer of, quote, free care from the public health service. More recently, the book and movie about the development of the HeLa cells in 1951, the first human cell line, next slide, from the body of a cervical cancer victim, Henrietta Lacks, without her or her family's knowledge, is sometimes invoked as well. Here is another example with use of parts of a Black person's body without consent or knowledge. Next slide, please. For other people of color, there are additional experimental medical stories that also circulate, whether it is extensive, unconsented sterilizations by various state agencies or the Indian Health Service, the use of Puerto Rican women to test the first high estrogen dose birth control pills, the yellow fever experiments by Walter Reed in Cuba, or as you noticed before, the one I worked on, the giving of sexually transmitted infections to Guatemalan prisoners, medical patients, soldiers, and sex workers. There are, however, and this is the last point I really want to make here, limits to the renaming of these horrendous events as a form of explanation for mistrust. Here I want to step out of my role as a historian for a few minutes to make some concluding remarks to understand how that history is or is not used. For acknowledgement of the existence of these past tragedies matters, of course, but it doesn't explain much if it is used by practitioners to demonstrate some kind of limited knowledge or cultural competency about the roots of the anger and pain of people of color and assuming that it's all from the past. It fits if we do this within the limitations of knowing a little bit of history about a culture that somehow supposedly overcomes bias and stigma to create the communication skills to link patients and their providers. Real issues of structural racism are in fact hidden when Sims, Tuskegee, and Lax are evoked. Just as learning a few words in medical Spanish or knowing about food deserts doesn't make researchers and practitioners competent in the racism that shapes our society. Almost like the dated culture of poverty arguments from the 60s and 70s, which posited that poverty created lifestyles and family structures that could not be overcome, it's time to stop using iconic events of medical abuse to explain contemporary fears. If we are to take systemic racism in the medicine and public health seriously, I think a different set of questions needs to be asked when we take the history of a patient or subject. The query should be about the disrespect and dismissal experienced as an individual's last medical encounter, or the treatment of a family member at a nursing home that builds on a lifetime of racist experiences that matter in creating that distrust. It is in all the episodes of everyday racism that work across race, gender, and class, undergirding our stratified society, including lack of decent housing and education, transportation, food and exercise access, mass incarceration, and enforced poverty that is proven over and over again to be what creates disparities and different health outcomes. Despite generations of searches to prove the logic of difference in the bones, hearts, lung capacity, pain tolerance, or genetics of people of color, disparities in social epidemiology research has demonstrated the structural creation of ill health and its epigenetic effects that carry on through generations. Although this is not the intention, sometimes evoking the historical studies also labels those who acknowledge them as somehow looking backward to some distant worry that should not affect a more modern people now. It makes it seem as if change is not possible because this burden of history cannot be overcome. These studies do matter, but they matter for what they show, what was happening is what's happening now, not just what was done in the past, and they show us the structures of racism that didn't disappear. The horror stories throughout our history matter in laying bare the underlying disrespect and flawed science of racial difference. Racial differences and experiences matter as the current political upheavals over access, Black deaths from disease, and especially the Black maternity mortality rate, or the police make clear. Including a historical perspective can tell us where we have been and how we as a nation have failed to incorporate lessons from previous epidemics that reveal the system of racism in perpetuating health inequalities. Physician and public health advocate, the late H. Jack Geiger, wrote over 20 years ago that history is important, he said, because it underscores the extent to which racism, fluctuating in intensity, shifting in content, but ever present, is still a major public health problem and a challenge to the goals of medicine and science. And he continued, the failure of efforts to address racism reflect an abandonment of racial justice and equity as national goals. It's not just history. Cultural competency, then, demonstrated by evoking a few terrible historical examples, does not show structural competency or an understanding why mistrust exists in the face of an untrustworthy medical and public health system. Last slide, please. It does because of real experiences of the everyday, experiences alas that more and more Americans of every racial and ethnic group are beginning to acknowledge. Thus, those of us in the health field have to acknowledge the history as we take seriously the need to address the structures of racism that are the greatest health risks of all. Thank you.
Thank you, Dr. Reverby, for sharing your expertise with us and providing this rich historical perspective on how medical mistrust has really been embedded in our history and continues to impact us to the present day. For those of you who just entered, I just wanted to send a reminder that if you have any questions for any of our panelists, please place them in the question and answer box, and we'll have a question and answer session after all of the speakers have spoken. I'm now pleased to introduce our next speaker, Dr. Leon McDougle, who will discuss the pervasiveness of medical mistrust in the context of COVID-19. Dr. McDougle is MD PhD, is the first African-American professor with tenure in the Ohio State University Department of Family Medicine, and he's the first Chief Diversity Officer, also known as Chief Collaborating Officer for OSU Wexner Medical Center. A graduate of the University of Toledo and OSU College of Medicine, he completed the family medicine residency at the Naval Hospital Camp Pendleton, California, and earned a Master of Public Health degree from the University of Michigan School of Public Health and Department of Health Management and Policy. In addition, he received an honorary doctorate degree from the Eastern Virginia Medical School on May 15, 2021. Please join me in welcoming Dr. Leon McDougle. Thanks.
Thank you so much, Dr. Brown. Next slide, please. So for our objectives this afternoon, we're going to speak to mistrust, not only in the lay community, but also among healthcare professionals. We're even going to speak to how levels of mistrust have resulted in public health implications for vaccines that have been routinely given for years. And then we're going to identify health professionals with highest levels of trust in the community. Next slide, please. So I thought I'd start out this afternoon by highlighting an important person. And I really love this quote regarding what one trusts. She said, "I trust science." And remember how often this science questioning of science has been part of the national discourse, and went on to say, "What I don't trust is getting COVID-19. So anyone know who this is? Maybe take a guess. All right, if you could click. So this is Dr. Sandra Lindsay. She was the first person in the US to receive the COVID-19 approved vaccine in December of 2020. How fast time flew by. So next slide, please. So I wanted to highlight here our standard bearers, our scientific bodies, our approval authorities were also called into question during the pandemic. And yes, as it says here, Black doctors didn't trust what was being said by the FDA, and this is referring to the National Medical Association. And we, in fact, passed a resolution in our House of Delegates to create a COVID vaccine task force to evaluate the COVID-19 vaccines and therapeutics. And this, I want to share with the audience, really caught national attention. The fact that we as members of the National Medical Association weren't taking at face value the recommendations being put forth by the Food and Drug Administration. And Dr. Reverby spoke to trust and is trust normative. And so with this, as president of the National Medical Association, I was able to convene a task force of experts in pediatric infectious disease, preventive health and public health, and members of the CDC Advisory Committee on Immunization Practices. So about 7 of us, and we met with Moderna, we met with Pfizer, and we wanted to speak to what was being done, the results that were forthcoming from the position of Black doctors treating Black patients. And in fact, we're in great support of Moderna actually having to pause the phase 3 clinical trials because they had not reached a threshold of about 10% of the participants participating being Black. So next slide, please. So with this, you'll see the date here is December 21st, about a week or so after our starting doctor was the first to receive the vaccine. And what we did in this, we spoke to how we queried Pfizer and Moderna about, well, what have you done? Have you included persons in these clinical trials who have autoimmune diseases such as systemic lupus erythematosus? Have you included persons in this clinical trial with HIV? And in fact, they were included, persons with HIV with a CD4 count of greater than 200 and a negative viral load. They were included. Did they include patients with sickle cell? That group was also included in the study. So we, in fact, published our findings and were in support of the ACIP and FDA approval for emergency use authorization of the vaccine in December. Next, and you can go to the actual publication through that link. So this was followed up by, I spoke to earlier in our objectives, what did Black doctors, Hispanic doctors, and physicians and pharmacists. Okay, so I talked about our task force. So the University of Houston School of Medicine collaborated with our organizations seen here and asked the question, would you recommend this vaccine for your family member? Have you, in fact, taken the vaccine? And which was a very, I think, were good questions to ask when we talk about trust. And what this revealed, about over 90% of Black and Hispanic physicians were in the affirmative with those questions asked, and about 75% of pharmacists with an increasing trend over time regarding confidence in the vaccine. Next slide, please. So now let's turn towards our normal, well, let's turn towards our youth regarding COVID-19 vaccination. And you'll see here with a Kaiser Family Foundation study published recently, and this goes from the time frame of November 29th of 2022 to December 8th of 2022. So we've been improving. We've done a good job with over 75% or so of the general population receiving at least one dose of the COVID-19 vaccine. With this being a convening of child and adolescent psychiatry, I wanted to also focus on that respective age group concerning mistrust and trust regarding COVID-19 vaccination. So you can see here with this chart that we have a long way to go regarding building confidence in the COVID-19 vaccine. Next slide, please. Now, what I was referring to, so our measles, mumps, and rubella, those vaccination programs have been going on for decades. And you can see here, I know there is a lot of data here, but let's just focus on the left, my left side of the chart. It speaks to parents should be able to decide not to vaccinate their children, even if that may create health risk for other children and adults. So we're speaking about our beloved community. So let's look at comparing 2019 to 2022 December. So in fact, it goes from 16% in October of 2019 to that 28% in December of 22, thereby putting our community at greater risk due to this lack of agreement regarding whether these standard immunizations should be standard practice. And then if you look at the right side of that with the lighter blue bar, so healthy children should be required to be vaccinated in order to attend public schools because of the potential risk to others when children are not vaccinated. And you'll see even there in 2019, there were 82% of people surveyed agreed overall with this, and that declined to 71% in 2022. So if we scan down, I want to really point out something, and I think maybe in part media driven and leadership driven. So if you look at the difference between Republican or Republican leaning population as compared to Democrat, you see there's a big difference between on the right side, now 44%, 20%, up to 44% now, think that parents should have autonomy regarding this, despite the fact that it may increase risk for others. And then on the right side, in the lighter blue, we've gone to agreement with standard immunization policy from 79% to 56%. So in shaping and describing some of the current status of trust and mistrust, I thought this was an important slide to share with everyone. Next slide, please. Now let's talk about from a standpoint of trust and ethics. This is an excellent depiction from the Gallup poll. And you'll see here that out of the various medical specialties, that nurses, in fact, have the highest degree of trust in the overall community, followed by doctors and pharmacists. Now that peaked in 2021 is now declining more towards prior baseline. Next slide, please. You'll also see here, I just wanted to give a broader viewpoint on trust and honesty and ethics regarding the general population. And you see here again, nurses, followed by medical doctors, pharmacists, and at the bottom, telemarketers. Also, I'd like to share with you regarding the likelihood for vaccination regarding the various racial groups. There's an excellent depiction on the CDC website. I can include that in the chat. It's really busy and you can manipulate it and so forth. So I didn't want to include it in this presentation. I just wanted to share that with you. So I think my last slide is coming up here. So just wanted to acknowledge Dr. Lindsay and share with you also how she received recognition by President Biden. She is a naturalized US citizen from Jamaica, received a civic award from that respect, and then also given the Presidential Medal of Freedom. So thank you so much for inviting me. That's my presentation for this afternoon. Thank you.
Thank you, Dr. McDougal. I'd like to now introduce our next speaker, Dr. Eraka Bath, who is an associate professor and vice chair for Justice, Equity, Diversity, and Inclusion in the Department of Psychiatry at UCLA. Her presentation has been pre-recorded, but she will be available for the question and answer session.
Okay, good afternoon, everyone. I am thrilled to be here to speak to you about strategies and supports to address medical mistrust and promote cultural understanding. My name is Dr. Eraka Bath, and my pronouns are she, her, hers. I am an associate professor at UCLA in the Department of Psychiatry at the David Geffen School of Medicine. And I also work in the Justice, Equity, Diversity, and Inclusion space. First, I'd like to start out with the land grant acknowledgement. Land acknowledgements are really recognitions of truths. They're kind of verbal memorials that speak to honor the indigenous peoples. And so like a memorial, a land grant acknowledgement pays respect to indigenous people by recognizing where they came from and affirming. And so we pay respect to ancestors, elders, relatives, past, present, and emerging. And the UCLA land is on the Gabriellingo and Tonga First Nations people. And my disclosures in terms of where I've received funding from historically and currently. So we're here to talk about medical mistrust, and really let's define medical mistrust. And it really encompasses a lack of trust in the healthcare system and the different entities that belong to it. So it extends from system actors, such as providers, to types of treatment, and different points of interface along the health continuum. And it's really critical to recognize medical mistrust as a huge factor in creating health inequities, particularly among ethno-racially minoritized groups. And many times the mistrust is actually legitimate distrust because it's driven by individuals' beliefs that providers can be unethical, that systems are not really, they're designed to protect them and provide sanctuary. And it's based on longitudinal and historical concerns. And communities of color, racial, ethnically minoritized communities, Black, Latinx, Native American, and other communities that experience intersectional oppression and harm do report higher rates of medical mistrust. And this is all really due to historical pinnings and current interactions with the health system, where there are continued experiences of discrimination within a landscape of systemic racism. And it's important to know that this is heavily documented in the literature, and that just the experiences of discrimination and concerns about perceived discrimination can impact engagement in care and aggravate feelings of medical distrust. And really, if we think about how health inequities are sort of situated socioeconomically and structured by social determinants of health, we can see how many of these factors in terms of economic stability or instability, the types of neighborhoods where people live, what's available in schools, food insecurity, community and social systems, healthcare safety nets, all of these have a line of structural racism through. And so there's inequities that are perpetuated on certain groups more than others, those who are structurally disadvantaged, and these can aggravate medical mistrust. All of these things in total really have aggravated distrust, and it's estimated to be for Black Americans some of the worst experiences. So in a 2020 poll, 7 out of 10 Black Americans had the perception that they're treated unfairly by the healthcare system, and over half felt that they distrust it. Thinking about HIV and how medical mistrust and distrust ends up getting propagated into different myths around scientific illnesses such as HIV or COVID. One survey that looked at nationally representative population of Black Americans found that over a third agreed strongly that HIV was a man-made virus, that 40% that there was a cure, but that the government was withholding it. And that a third also felt that the doctors prescribing medication were prescribing poison. And so it's important just to never think about the concept of medical mistrust de-anchored from historical underpinnings. And I didn't include this slide today in my deck, but I often like to have the Sankofa bird, which is a Ghanaian symbol, and it talks about the importance of the historical context. And the bird is actually looking over their shoulder to bring the lessons from the past forward. And so as we situate our conversation about medical mistrust, we need to think about all the sort of repeated acts of harm that have led us to the current state. And not only the acts, but things that were sort of codified by policies, practices, procedures, and programs. So the spillover effect is really relevant too, as we conceptualize trust, medical mistrust. And so prior research has found that if there's distrust in one institution, right, such as experiences of law enforcement, this can aggravate distrust in other institutions. So if we think about just systemic racism and how it's operative in all the different structures we have, so the education system, the healthcare system, the housing system, these sort of spillover effects that potentiate marginalization are additive and then can also aggravate what happens in the healthcare space. And so we really need to think about discrimination broadly. There have been a lot of movement in really thinking about racism as a public health issue and a public health threat. And this, I think, really underscores the challenge of the spillover effect, because people are experiencing discrimination in non-health contexts, right, repeatedly every day. And so that's going to impact how they experience the medical system. And so we really need to start disentangling that. Some ways are really to sort of think about improving patient-provider relationships. And so that's building trust, using empathy, and thinking about relationships outside of exam rooms, but also dealing with structural determinants. So thinking about affordability, thinking about access, and actually naming racism. Okay. I am going to give an example of a promising program that I learned about related to pregnancy and perinatal care for Black women. So we know that lots of data and news articles about this, that Black women are 3 times more likely to die from pregnancy-related causes than white women. So in 2019, and this stat and disparity has been, you know, sadly persistent for quite some time. And so Merck for Mothers brought together Black women and perinatal care professionals to really download about the challenges that they've experienced during delivery, what sort of, how the clinical interface was troubling, both prenatal, postnatal, and really co-creating solutions with people with lived experience. And so it's centering the voices of people who are historically marginalized and not really able to have agency in their care. And the Merck mothers found that this is really key to building trust and exploring these sort of safety concerns or goals for childbirth, because really, when are women asked? And so some of the questions that guided this were like, what's most important to you about your birth? What do you know about birth? Really teasing out what health literacy they have, teasing out any fears and concerns, understanding that they may need different things to feel safe, and getting feedback on their care. And I feel like this sort of blueprint is something that's very easily applied to the mental health space, because we have these same gaps in communication. And so the hope was from this is like being able to sit down and really ask the patient their perspective and how they want to sort of navigate experience and engage in care really can flatten the hierarchy. this notion of using empathy and not arguments. And so one of the things that around vaccine trials, right, there was concern about the enrollment of Black patients, but also how do you get people to take the vaccine, right? And so sometimes this shock and awe notion that we as clinicians have with data, with what we call science, can be very not empathy generating, right? So it's important to give information, but we really need to sort of think about empathy and cultivating that in the clinical interaction in a way that's transparent and authentic. Also building relationships outside exam rooms, which rarely occurs, but this is something that's really important. And so there's this program called The Third Conversation, and it's really designed to have a separate conversations about healthcare experiences and frustrations. So it's a way of, having a clinical space where you're giving the information, you're giving the treatment plan, but also creating additional spaces for feedback to get their experiences about how the relationship is going, allowing space to vent frustration or concerns. One huge issue is attending to affordability and access barriers. So many patients believe they're treated with less respect by healthcare providers because of their income, because of the type of insurance they have, because of their race. And some may feel that care may be withheld or they may not receive the best care because of a combination of these things, right? So people's experiences, and they're showing up in an intersectional way where there's no such thing as a single issue struggle, as we do not live single issue lives, as Audre Lorde said. So having the multiplicity of marginalized identities, being uninsured or underinsured, being from a socioeconomically disadvantaged background and being from a racially minoritized background may all be occurring and impact how people engage with patients. And so one current issue that's been persistent is research participation. We have a problem in this country of weird science that stands for Western educated industrialized rich democracies, which was a term put forth by Henrich, who talked about how our research enterprise is weird and not really representative of the inclusive, diverse spaces. And so what are the barriers for Black Americans and other non-white people to participate in research study? And its mistrust really emerged as a primary example. And so City of Hope, which is a pioneering treatment facility for cancer, really wanted to address this and took actual steps to think about meaningful engagement to participate in some of the research trials. And so patients were invited to complete surveys to really get at their experiential, social, emotional, and financial problems, and really sort of exploring what the social determinants of health might be that may impact them in treatment. So how do we create safe and welcoming environments? And I like to start with what is positionality. And not everyone is familiar with this, but I think it's really important to sort of reflect as a provider, who am I and what is my lens? And so when I'm speaking about positionality, I'm speaking about the sort of social and political context that creates my identity. And this is informed by race, ethnicity, gender, socioeconomic status, ability status, age, citizenship, all these things and more. And these social and personal identifiers really impact my biases and my perceptions and outlook on the world. And so another way of thinking about it is looking at this privilege wheel, right? Where we see the intersecting axes of privilege and domination of oppression. So I started out my talk giving my disclosures, right? But really, my financial disclosures do not tell where I fall in these layers of oppression, marginalization, and privilege. And one of the things I think as providers to really be more attuned to the type of work is to actually think about your own positionality as you interact with patients. And so I identify as a Black cisgender heterosexual woman. I am the daughter of Black physician activists. I'm a mother to a teen. I work in academia, but also work in juvenile legal and child welfare systems. I'm working in predominantly white institution, but also graduated from an HBCU. So thinking about what lens we are bringing, know thyself, and how that shows up in the clinical environment is really important, because one's positionality and the failure to reflect on it can have lots of downward effects, both in research and in clinical interaction. And so we really want people to sort of start thinking about this as a primary driver, and really having clinicians do an honest and thorough self-examination of their conscious and unconscious attitudes, and particularly around race, privilege, and really rejecting, checking oneself to see, like, what are the assumptions that we make about cultural homogeneity, and how can we provide sort of more contextually based mental health care. And it's going to start from that self-knowledge. I wanted to talk a little bit about this concept of epistemic injustice, and this is a term brought forth by Dr. Miranda Fricker, and it really talks about the production and spreading of knowledge is really an essential part of being human, but who's allowed to count as a knower, and who's allowed to be bearers of knowledge, that has changed. And this matters when we think about the clinical space, because many times patients have the experience where their complaints and concerns aren't listened to. We have so many different levels of inequitable outcomes really in the health setting. We know that there are studies that show medical students have misperceptions around Black pain, density of Black bones, all these different things, right? And so when patients are highlighting needs, this notion of epistemic injustice is really, I think, aware. And so to prevent epistemic injustice, we really argue that we need to cultivate character traits within ourselves, right, that neutralize our prejudice and biases. And we should be aware of our biases and prejudice in terms of who we judge to be credible. And so many times, one of the biggest forms to aggravate the medical mistrust is that patients who are structurally vulnerable are not really thought of as credible or as knowers, right? And many times when people are victimized by prejudice, they can have undue difficulty articulating their experiences. So two important arms of epistemic injustice, there's two. So it's testimonial injustice. And so these are often related to these intersectional phenomena, race, gender, accent, and they can be caused by prejudices in the workspace. And then hermeneutical injustice really relates to interpretation and understanding. And really it's about some groups sometimes lacking the literacy or the knowledge to communicate an experience. And then this often has an aggravating effect on their testimonial injustice. So one ways in which we can think about creating these safe, welcoming environments are really thinking it at the structural level. So how can health systems actually interact differently with people? So one example is work done by Hofstetter and Klein, where they looked at LGBTQ populations. And there was this sense of mistrust in not wanting to divulge information about gender identity or sexual orientation. And more than 50% of people in one study who identified as LGBTQ felt that they experienced some discrimination based on their gender and sexual identity. And so one of the things they did in terms of creating a safe space was actually creating the first LGBTQ clinic in Cedar Rapids, Iowa in 2018. And they wanted to actually acknowledge what staff didn't know, and get input from community members, so people with lived experience, by holding a series of town halls. And so this is this notion of like allowing the patient to actually be the learner, shifting this sort of hierarchy where physician is always the teacher and the patient is learner, but having, you know, more of a bi-directional flow, and then making staff participate in regular trainings, and really cultivating allyship, and also putting in place consistent routines, like people asking about their pronouns. So another important program I want to highlight is the Think Cultural Health Initiative, and you can Google this. It's part of healthandhumanservices.gov, and they put together something called the National Class Standards, which we're going to talk about, but it's really to advance health equity at every point of contact. And the class standards are critically important. They stand for culturally and linguistically appropriate services, and it's really to help reduce disparities and achieve equity. And it's really about respecting the whole individual and responding to the individual's health needs and preferences. And so it's really centering the perspectives, recognizing people are embedded within their socio-ecological context, positing the patient as expert. And so really it's believed that adoption of these standards will help advance better healthcare in the US. And it means thinking about cultural health beliefs and practices. What are the preferred languages? Thinking about health literacy and other communication needs. And the class standards have really a set of 15 action steps to improve health equity, improve quality, and eliminate healthcare disparities. And they really provide a blueprint not only for individual clinicians, but also health and healthcare systems to begin to implement culturally and linguistically appropriate services. This slide is really hard to see, but you can find it on the Think Cultural Health website. And it really takes a structural approach to eliminating health disparities by having a guiding principle, thinking about governance, leadership, and workforce, really enhancing communication, and not just communication to those who are primarily English speaking, but those who have limited English proficiency, and then engaging in continuous improvement and accountability related to quality improvement. Another study that's really important that the US Department of Health and Human Services engaged in was thinking about health literacy, right? And so when we think about health literacy and where that fits into mistrust, that is something that we really want to cultivate in the patients that we take care of. And so understanding health literacy is key. So personal health literacy really reflects the degree to which individuals are able to find and understand and use information services, right, in a way that they can impact their own sort of care. So it gives them self-agency, self-determination. And then, you know, there also needs to be organizational health literacy. So how equitable is your organization? How easy is it for people who are interacting in your organization to find and understand and use information? Are we, as a workforce, training our systems to promote organizational health literacy for the end user, the patient? So these are different things to think about, but they're part of the Healthy People 2030 campaign. And so we really want to emphasize people's ability to use health information rather than understand it, right? And so it's like making well-informed decisions rather than appropriate decisions. But if you think about all those different structural determinants of health and along the axes of privilege and marginalization, there's many different social assaults to someone being able to do that, particularly if you have a health system that isn't sort of centering the need for this. And it's really critical to think about even the patient pamphlets that we have. What are the signage that we have? Do we have things that are in multiple languages? How do we access interpreter services? And what are our attitudes around that in terms of our interacting with patients? These are all key to alleviate medical mistrust and cultivate a trusting, equitable environment. And so one of the key findings is really not blaming individuals for not understanding information that has not been made clear, and really sort of thinking structurally about all the different assaults maybe to someone's health literacy and removing those barriers, and understanding that educational attainment alone isn't an indictment for who should understand what. And so really making sure that other health professionals are communicating accurately in a way that is also centering the patient concerns. Okay, cultural competency, just a few words in talking about this. Really, if we're thinking about workforce development and how to sort of make organizations and our providers that we are training more able to cultivate trust, we really need to think about cultural competency, cultural humility, and cultural attunement. And so the AAMC has actually deemed this as a vital aspect of every medical school's curriculum. And I would say that this also extends to the graduate medical education space, where it's really important to train residents and fellows in this. And so just understanding cultural competence really is a set of similar beliefs, attitudes, and policies that come together as a system or among professionals that enables effective work in cross-cultural institutions and situations. And we are in an inclusive space, so we need to be thinking about this, really making sure that we are understanding the implications of limited English proficiency and how for people who don't have, who have a limited English proficiency, that they should not have lower health outcomes, and recognizing the civil rights connections to LEP status, and making sure that we are not engaging in discriminatory or inequitable practices. Language is really key, right? And so language is one of the most potent barriers, both in distrust, mistrust, and in cultivating trust. And so we really need to think about this as a key lever to address cultivating trust. And the clear communication resource pages actually were developed by the NIH. And it's really this growing health literacy movement that really is designed to increase information sharing of NIH products. And really the Office of Communications and the Public Liaison assisted the NIH in developing a range of materials. And so this would say, I would say, if you're trying to address medical mistrust, this is a key resource in addition to the class standards. That's part of how to have effective health communication. There's also podcasts and lectures available on this site. And one of the key things, right, is establishing clear communication, being aware of nonverbal cues, and ask openly about potentially relevant traditions and customs. Don't assume that you know, or make monolithic homogenizing judgments about a patient's cultural group, like thinking all Black patients do this or all certain groups do this. Ask with cultural humility. Also, be sure to use normalizing statements as a way of asking about sensitive sensitive topics. So sometimes you may have had experience with certain ethnic or racial groups, and you may think certain customs apply. And so you want to sort of show some sense of knowledge, but you don't want to tokenize or stereotype. And so there's a way to explore that. And as I said before, really examining your own biases. So really reflecting on your positionality, and know that you're going to bring bias into the space, but understanding them and having sort of bias checks are helpful. So moving forward, I really think that as a system, we need to think about, really documenting and understanding the reasons fueling medical mistrust and anchoring them in the historical. We need to really understand different ways of actually involving people with lived experience in the healthcare enterprise as knowers. So this can be in the form of peer navigators, promotoros, different sort of ways to actually expand and support patients, centering the histories of racism in medicine, and making it a required part of health professionals training from medical school through residency, and really also thinking structurally about identifying systems of disparate care, and then hire Black, and I would say women and non-English speaking people in clinical and leadership roles. Really thinking about, in terms of the historical roots, I can't really emphasize this enough, because once people understand the historical roots, it does allow them to incorporate more empathy, and it also gives them more anchoring in some of the structural factors that impact the treatment of patients and how patients can engage in care. And also, I'd say incorporate interpersonal and institutional measures of perceived discrimination into performance evaluation systems, and also in the clinical encounter, right? Because how someone's experiencing discrimination, and if they're experiencing discrimination, that's going to have an impact on their health utilization. All right, thank you.
Well, thank you to all our speakers for such great presentations on this very complex topic, going from the historical perspective to mistrust impacts on patients and even healthcare workers themselves, and providing that guidance to help us address it. I would now like to start the question and answer session with our panelists. So if they're able to turn their screens on. The first question I have is for Dr. Reverby. How do you think we can get the history of mistrust into medical, nursing school, and other allied health providers' curriculum?
My story is that one medical school dean once told me that it was easier to move a graveyard than to change a medical school curriculum. So that starting with that as the baseline, which I think is actually true. I think one of the necessity is so at the beginning of scientific training in the United States for medicine, it was believed that the history actually really mattered. The doctors at Johns Hopkins thought that teaching history what mattered. And then all my friends who taught in medical schools kind of got pushed out as the bioethicists came in. So I think one of the things we have to really think about seriously is how do we require this kind of understanding as part of the curriculum and see it as important as an advanced class in chemistry. I think the more we do that in nursing schools and health professional schools, the more it will help. And I also think it matters that we teach this at an undergraduate level. I did it for 35 years at Wellesley, and I always felt like I had to get the students before their brains got ruined when they got to professional school. So it matters all the way along the line.
I'd like to add also that with the uprising increase in social awareness and consciousness that has occurred, demands have been placed on medical schools by the students themselves. And I know at our institution at Ohio State, we have a task force. We're reviewing the entire curriculum. We're looking for opportunities to include information about history relevant to the system that's being studied at the time. There's a tool, a bias checker that we're reviewing the curriculum with also to start. So there is an urgency now that is providing an opportunity for these changes to occur.
And then Dr. Brown, can I just add to that too? Locally at UCLA, where I'm from, we, in the spirit of the uprisings, they ended up actually creating positions for structural racism theme chairs within the medical school. And so now it is part and parcel of the standard medical school curriculum. And there's a push, at least in the Department of Psychiatry, where we actually have structural racism coursework throughout all PGY 1, 2, 3, 4 years, also in the Child Fellowship as it pertains specifically to mental health. I think that there's efforts underway to do that across the GME space, but I think most medical schools, I hope, have gotten the memo that they need to keep that. I think from a structural competency perspective is thinking about making sure ACGME and LCME actually have clear standards around that education, right? So how many contact hours, just like we have to have X number of hours of physiology or anatomy, but actually lobbying us as medical professionals, lobbying the agencies to make sure that there's clear accreditation standards. And I think we can leverage the power of all of our different professional agencies that have also recognized racism and structural racism as a public health issue. So everyone from the NIH to the American Psychiatric Association, AMA, AAMC. And so we need to sort of bridge that disconnect, right, between all these organizations sort of documenting it, but then how do we sort of translate that into the educational space? So I do think that that's going to be making sure the accreditation standards are there.
Thank you. So I have another question, and this one is for Dr. McDougle. As an African-American male and physician, do you have thoughts on how to support African men and boys to access mental health care, especially given the rising rates of suicide in this population and evidence that mistrust may be playing a part in seeking care?
Very good question. I answered some in the chat. I'm going to even expand upon that. So what I initially mentioned in the chat, there is a great need to increase diversity in the mental health professional workforce, also embedding mental health services within primary care centers and clinics. And what I'd like to add to that, so our boys are being criminalized in elementary school. And so there is a great need for the school system to partner with our health professionals. And so what's happening is, say, a Black boy does something is deviant or discordant behavior. A European American child does something, well, you may have, we need to screen you for behavioral ADHD and things we can give you. So, and even with that difference between being identified as more misconduct or problem child versus having a treatable method, even the screening. I published an article a number of years ago, even the screening test for ADHD, many of them have not been validated with a substantial percentage of persons of color. And with our findings, the Vanderbilt had been developed in such a way, and also the Terry. So that's about 2010 publications. So one, just the whole ideal about, are we even going to explore the possibility of mental health disorders with Black boys versus putting them in the space where they're just behaving badly. So I think it really needs to start there, in that connection with the school system.
Right, thank you. We have two questions sort of related to this topic in the question and answer box. So with the various bills being brought to the forefront in Texas and Florida regarding dismantling DEI initiatives, the question is really, how can we address these medical mistrusts when we're sort of getting blocked from discussing structural racism? And so, what can we do to sort of address that issue?
Who's that to? I can start.
This is open to any of the
Okay.
panelists who'd like to chime in.
So first of all, it's American history. Second of all, from a health perspective, it can be framed in social determinants of health, right? We talk about social determinants of health. So you can say what you want to about that. Those aspects of care and outcomes are real. So I would just say, we're in the health profession, frame it in health professions terms. And I think that will go a long way regarding being able to do what we do and to advance health equity. Those are my thoughts.
And Dr. Bath, I think you said you wanted to make a comment as well. And then Dr. Reverby.
Oh, Dr. Reverby, go first. Yeah.
Oh, okay, I'll just be quick. So I think there are two things. One is obviously this is a political struggle, and we have to get people engaged in fighting these kinds of laws in these various states. But so that's the long-term strategy that we have to do in terms of getting people to vote and to get these people out of positions of power. But in the meantime, I also think we have to think about the kinds of things Dr. Bath talked about that we could create online that students could get to, even on their smartphones, even if they don't have broadband at home. I worked with the TED Ed people, for example, and I did a version of the study in Tuskegee in 5 minutes in an animated 5-minute thing. So I think there are ways to think about using the internet that at least at this point, they can't stop us from using in these various states. And I think it's worth thinking about the professional associations being part of that educational process.
Well, and I love the suggestion about ACAP maybe playing a role in addressing this issue because, there's so many cities, legislation, and organized medicine entities that have declared racism as a public health issue and threat. And so as Dr. McDougle said, sort of situating it within the public health realm, I'm not aware of the assaults on us learning about racism as a structural determinant of health yet in the medical spaces within those states. But I think that that's why thinking structurally around making sure there's accreditation in naming racism as such and teaching about it.
And Dr. Benoit in her comments mentioned talking about training directors and heads of departments being able to talk about this and from a viewpoint of the social determinants of health, as reiterating exactly what the two of you are saying. And regarding ACAP, there have been statements that have been put forth regarding such things that have come forth from Texas and Florida. Dr. Ng has put forth a statement from ACAP. There are policy statements that talk about these things. And for all of you that are involved in your local regional organizations, your ROCAPs, bring that forth in each of your states locally. And you also bring that and remind you that we as ACAP go to the Hill each year in May. This year it's May 8th and 9th, and we address mental health needs. And we highlight, address, and talk about mental health needs from the perspective of child psychiatrists and just everything that the families need from that perspective. So these things come up. So what are we doing as ACAP is the same thing as that you're doing as an individual in terms of having these difficult conversations and educating and bringing light to it. And we only have just a couple more minutes for this forum. So are there takeaway points that the three of you would like to give the audience before we end? And we're so thankful for your time. We're so thankful for Tashalee Brown moderating it. We're thankful for Carmen Thornton in making sure everything happens, and for all of the ACAP staff, Quentin and Alex, that make sure that everything that we do today stays on point. I'll start with you, Dr. Bath.
Yes, well, I was thinking about this notion of structural determinants of health, social determinants of health, and in the clinical spaces, because, the conversation needs to go beyond the theoretical. And so we need to actually do things differently and really think differently about how we're interacting with patients. So one of the things we're starting to implement at UCLA is actually implementing and putting social determinants of health screeners as part of the intake process. And that enables you to have a different type of conversation and addressing those different domains with intentionality. So we're doing that really to think about it as far as the healthcare goes, and then also looking at our own outcomes for patients. So what's the difference in terms of seclusion and restraint, number of days stayed, looking actually at patient outcomes by race, ethnicity, and gender to make sure that there's not inequity in those spaces as well. And also starting to use more peer navigators.
Dr. Reverby?
I'd say, and this may go against my professional status here, but I think the history matters, but it only matters so much. And I think it's too easy to say, oh, it was Tuskegee, and then for practitioners to say, for example, oh, that happened a really long time ago, and I'm not racist, that was the old guys, right? And I think it's really, so when I talk about it, I always say, okay, let's describe what happened in these studies and think about how terrible it was what these doctors did, but let's think about how easy it would be for you to be them. What were the mistakes that they made? What were the structural pressures on them to produce, to get stuff, to the hierarchy that makes this happen? So I think one, this stuff has to be taught that way with an eye toward what it means now in health professional schools. And I also think it's really important to teach the history of health activism, which I did at Wellesley, but I also think should be taught in schools to understand the relationships and the allyships that's been developed over time. Again, my great hero, Jack Geiger, for example, wrote prescriptions for food, right? Before there were stamps. So he wrote prescriptions for food because he realized that that was the most important thing he could do for his patients. So learning that history and what can be done and what has been done, I think is really matters.
As CMS, Centers for Medicare and Medicaid, move more towards accountable care organizations, also make the business case for addressing social determinants of health.
That's right.
Business case, Dr. Deborah Plummer has written a lot about this too. So that's another way to proceed.
We thank you all for your time that you spent here today and for helping to educate and have this discussion. This will be on an ACAP website for future use. Also reminded that ACAP has joined with other organizations in terms of speaking against dismantling DEI programs in any states. So anytime that you can ally with others that share these points of view and are about educating and helping to decrease disparities and talking about the challenges that exist, we do so. And so it's not just one body, it's not just one institution. We are doing this collectively, and as much as we can continue these conversations, the better it will be for our families and children. So I thank you all for participating. Have a wonderful day.
Thank you. Bye.
Thank you. Bye-bye.
Thank you, Tasha. Thank you, Carmen.
Thank you.
Thank you, Dr. Bath,
Thank you,
Dr. Everett,
guys.
Dr. McDougle.